hemato-oncology. It's not like we don't get all those. It's just that we were not able to, diagnose appropriately. But then now I think we have everything in the city to go ahead with a good hemato-oncology setup, even in a private or in a government sector currently. So the motto of the talk was to, make sure everyone comes across these kind of cases and we're able to catch them at an early stage, because hemato-oncology is a very critical care kind of a medicine. And early diagnosis means a patient is going to do better, be it a small ITP, something we treat, or be it acute myeloid leukemia, the most dreaded disease. So we all know blood. This is the elixir of life. So we all know that there are three cellular components: the WBCs, the red blood cells, and the platelets. And the indirect indicator of what is happening in the body is what we see in the CBC. Something as quick, within 2 minutes, you have the entire status of what's happening in your blood in your hands. And it hardly takes 2 minutes, trust me. And what is actually happening? How do we present, or where does these things happen? The elixir of life, how was it made? The factory is the bone marrow, where we have something called the stem cells, which are so plastic and they can make all these three kinds of cells. So these are the normal ranges. So this is the right now approved international criteria: a hemoglobin of 13 to 17 for men, 12 to 15 for women. And the WBCs and the platelets are the same for both men and women. So if there's an increase in hemoglobin, we call it either as erythrocytosis or polycythemia. If there's a decrease in hemoglobin, we call it as erythrocytopenia or anemia. If there's an increase in WBCs, we call it as leukocytosis. If there's a decrease, we call it as leukocytopenia. If there's an increase in platelets, it's called thrombocytosis. If it's decreased, we call it thrombocytopenia. So there's a very narrow balance we are maintaining and homeostasis in our body. We are going to see how they can be deranged in any forms of diseases. So this is case 1. This was a 45-year-old male from Pratapgarh. He is a farmer by occupation, vegetarian, smokes BD 4 to 5 times a day, presents with chest tightness, itching, no other prior comorbidities or any other medications. On the general examination, the only abnormality found was that he was plethoric, no organomegaly, no lymphadenopathy. So what we see here, his hemoglobin is 18.3. His WBC is almost 27,000 and a platelet of 5.84 lakhs. So should we be worried in this patient? So what are the flags? He is a smoker. Maybe he has an underlying lung disease which has caused a polycythemia or the erythrocytosis. Not only is the hemoglobin increased, can we see that the WBC is also increased and the platelets is also increased? As we saw, the factory is deranged. It's not only one. All the friends are sick. The TLC is raised, the hemoglobin is raised, the platelets is raised. So the physician, one of the physicians who referred this patient to me, was very good. He did the serum EPO levels, which is the first thing we'll have to do once we identify it's definitely polycythemia. He also did JAK2, which was negative. So, we are in a soup. We don't know serum EPO is normal. We don't have a secondary cause of polycythemia. And JAK2 is negative, which means the myeloproliferative neoplasm is slightly unlikely. So the patient came to me. So why should we, as a physician or as a surgeon or any doctor, be worried with a hemoglobin of 18? Because you all know the virtuous triad. You cannot, it's just like tea, what I explain our patients. 2 teaspoons of sugar, the tea is, drinkable. When you have 4 to 5 spoons of sugar in the same cup of tea, it becomes thick and sticky. That's exactly what happens to your blood as well. When your RBC counts exceeds the amount of normal, it becomes sticky. So it can cause stasis anywhere. So what we are afraid of is epistaxis, stickiness causing to platelet consumption and bleeding. We can have a stroke, cerebrovascular stroke because of thrombosis. We can have an MI, and we can have some acute syndromes like Budd-Chiari. So we don't want such complications. So any doctor who comes across a hemoglobin of more than 16 should have their horns high to see what exactly we are dealing with. So what are the basic answers we should identify? Is it really true erythrocytosis? Are you sure the patient is not dehydrated? The patient is not any anabolic steroids? The patient is not having any diuretics? And have you seen the patient like 2 or 3 months before? And was there a tendency for an increased hemoglobin even in the previous report? And if it is absolute or relative is because of dehydration. For any circumstance, was the patient on diuretics? or was extremely, after an athletic workout. And the serum EPO level. The first and foremost thing that we have to do is to rule out serum EPO, because serum EPO is a stimulant to your factory. EPO or erythropoietin stimulates your blood factory, that is your bone marrow, to produce more RBCs. So we know there is something else which is giving signal to the bone marrow to produce more RBCs. Just like thrombopoietin is the one which makes platelet production more. GCSF is the one which makes the TLC production more. So first thing is we have to identify if it's true, if it's persistent, and we'll have to do a EPO level. Our primary concern is if it is malignant, if it is polycythemia vera. So in which case we might have to give cytoreductive therapy, we'll have to do phlebotomy, we have JAK inhibitors. So we'll see what happened to this patient. When the patient came to me, I did not hesitate a minute to do the bone marrow. This is the bone marrow we did. We can see the bone marrow was packed, it's completely packed. It means it's 100% cellular. There is no space for fats. A patient of 45 years, we will expect at least 60% fats. There is no fat at all. Absolutely pan-myelosis, this is what we call. So even in the absence of JAK negativity, this patient fulfilled the criteria of polycythemia vera. So this patient was a case of polycythemia vera. Why am I troubled if it's polycythemia vera and if it's not just reactive polycythemia? Reactive polycythemia will settle if we stop smoking, if it's because of metabolic syndrome, if he loses weight, but polycythemia vera is not going to. And in 5 to 6 years, or maybe in 10 to 12 years, depending on the underlying mutations you have, he might develop into AML. So we'll have to warn the patient, counsel the patient, initiate appropriate therapy. So the story is not yet over. You know how much percentage of polycythemia vera is JAK negative? Less than 2%. So JAK is not just JAK. JAK2 is exon 12 to exon 14. So there are a number of varieties of JAK. So whatever we say the lab to do JAK, it is not the entire spectrum of JAK. So when I did the marrow, I did for the entire exon sequencing of 12 to 14 JAK. He came out to be positive for JAK exon 12. And for my limited experience of 6 months in Allahabad, we have more patients with exon 12, which is a rare form of JAK mutations in this city and around. Probably because this kind of mutations is seen in the young males. And these are the patients who will go into thrombosis, be it MI, be it CVA, or be it Budd-Chiari. So it's imperative when we see a patient with persistent high hemoglobin, we will have to evaluate and rule out the possibility of underlying neoplasm. So we see this triangle. 95 to 97 is your conventional JAK positivity, which we usually do. Most of the physicians do the EPO and JAK levels, but 1 to 3% are JAK2 exon 12 positive. So we miss those cases. So we cannot label them as the patient is JAK negative and he's not polycythemia vera. And 1 to 3% might have other mutations also, the remaining one. So how do we manage? Again, the appropriate hemato-oncologist will classify the disease as low risk or high risk, whether the patient has thrombosis, and based on the age, and the management differs from aspirin to pegylated interferon to busulfan and the newly molecular drugs like ruxolitinib, which is a JAK inhibitor. So hematology is moving from just ecosprin and cytoreduction to molecularly targeted drugs, which are now available, not exorbitantly priced, and has good symptom control. So what if the patient was JAK negative erythrocytosis and the marrow was not suggestive of a myeloproliferative neoplasm? So still there's a lot of causes. So we should also keep in mind that not only malignancies and not only reactive causes of erythrocytosis, there are genetic causes of erythrocytosis. Say, for example, if the biopsy was negative in this patient for an underlying myeloproliferative neoplasm, I would have worked up for all these things like the EPO mutation. This is familial, and the patient will present with polycythemia. He will have risk of thrombosis. And what I will be doing in these patients is to target a hematocrit of 45 to 60 to prevent the thrombotic episodes. And these patients are very, very young. We don't want to afford rice winner of the family and lose his life for a cardiovascular accident. So this is very important whenever we have a flagging of more than hemoglobin 17 or 16 and it's persistent for more than 2 months and EPO is normal, he mandates further evaluation. So the case 2, since it was a complicated mutated case, we'll go for something very simple. This was a 33-year-old female, newly diagnosed with vitiligo. All these cases are from Allahabad. She was started on azathioprine at trial doses, as it is indicated, for vitiligo, it's topical immunosuppressant. The lady was very, very affected because of the cosmetic issues. She didn't want those white patches. It was not even on the face, it was on the chest and the trunk. But within 1 to 2 weeks of starting the drug, she started noticing severe malaise, hair fall, like massive hair fall, and painful oral ulcers. She did not do a CBC or she did not do an LFT, and nor was it required. Azathioprine is something which every physician uses, be it in ITP, autoimmune hemolytic anemia, be it in IBD, be it in ulcerative colitis, a variety of ophthalmological cases. So she visited the physician who started her, and the CBC was this. So you can see it was a pancytopenia. Any pancytopenia like threatens every physician, right? 8.9,500 and 75,000. And the patient was sent to me. This was a clinical image. This is the level of which she lost her hair. Within 2 weeks, she was a female who was just bothered about a small white patch on a truck, and she lost alopecia totalis. And I don't know whether it's very clear. So can you see this white striae? They were all mucositis, and she had pancytopenia. So any clues what it could be? This was AZA-induced myelotoxicity. Poison is in everything. Everything is poison. It could be just paracetamol or amoxicillin, or it could be azathioprine or MMS. It is a dosage which makes it either a poison or a remedy. So in a patient like this with azathioprine-induced mild even cytopenias, what should we do? We should do an LFT. You know why? These thiopurine drugs, especially the cytidine and 6-MP, they have a lot of enzymes involved in their metabolism. If one enzyme is missing, it can present as myelotoxicity or stem cell toxicity. If other enzyme is missing, it can present as hepatotoxicity. So how do we know what is the Indian status? I'm quoting my own paper. This is about to be published. This is a set of 38 Indian patients who was put on 6-MP and azathioprine consecutively in SGPGI. 14 out of 37 patients had underlying mutations. So that is a huge problem. So this means that you cannot give routine doses of azathioprine for almost 38% of the patients. So what can we do as physician whenever we start an immunosuppressant therapy, be it MMS, be it azathioprine? Always get a routine CBC and an LFT within a week of initiating the therapy so that we can catch these people early. So now what I did, I stopped the offending drug. I started him on TPO agonist. What we're having is stem cell toxicity. It's not only cytopenia, she's losing her hair, which means every cell, and she's having mucositis. Every cell which is rapidly proliferating in your body is being killed by azathioprine excess. It's not that the drug is bad. It's just that she's a poor metabolizer. And it's 40% is a huge number. So when we are starting on these cytotoxic drugs, it's imperative we follow the patient within a week of starting the therapy. So now the current, I just saw her yesterday in the OPD. Her current hemogram is 12, 5,600 with a 2.02 platelets. She's happy. I am happy. The treating physician is also extremely happy. So again, going on to something malignant, this was another case, 16-year-old boy presented with high-grade fever for 5 days with increasing malaise and EC fatigability. He's currently admitted under me at United. He was seen by his family doctor and was prescribed oral antibiotics. The fever did not respond. On examination, he was pale, had no organomegaly. Basic blood workup was done. This was a hemoglobin, 11.8, not very low for a person from Uttar Pradesh. TLC of 3,350 and a platelet of 22,000. Chemistry was all normal. So what are the red flags here? Fever, which did not respond to antibiotics. There is bicytopenia. Bicytopenia can be seen in nutritional deficiencies with some concomitant fever. But what is a red flag majorly is the grade 4 thrombocytopenia this patient had. So the patient came to me, I did a peripheral smear. All I could see was some lymphocytes and thrombocytopenia. I did not hesitate to do a marrow because grade 4 thrombocytopenia in itself in a non-pediatric population or even in an adolescent is an indication for marrow. Ideally, it is better when we are doing in private practice to do a marrow, even in pediatric patients with ITP, if you even have the slightest doubt that this is not ITP. So this was a marrow. It was jam-packed with blasts. So we did the flow cytometry, which was positive for CD5 and was positive for CD7, and it was negative for CD1A, which is almost a pan-T cell marker, and it had some myeloid markers. This is a very rare type of ALL. It's called early T cell precursor ALL. So this kind of ALL can present with subleukemic and aleukemic leukemia. The patient will have only mild cytopenias, And unless and until one day he presents you with 3 lakhs TLC and the blast from the marrow comes into the periphery. And the other sad thing about this case is that they are not as responsive as other conventional BALLs or TALLs. So this is something, we should catch early and start therapy early. So every cytopenia need not be evaluated further. You can always give a trial of B12, but when there's a grade 4 cytopenia of any lineage, be it anemia, be it thrombocytopenia, be it neutropenia, it always mandates further evaluation. Another case, this again was a case I think Mark sent me. 58-year-old driver, resident of Georgetown, presents with easy fatigability and malaise and nocturnal fever for 3 months. He was evaluated for 3 months by doctors, very rightly, with a hemoglobin of 9.8. The only thing is that the TLC was 28,000 with a mild left shift and some nucleated RBCs. Platelets was 2.1. GBP, there was a suspicion of myeloproliferative disorder. Repeated IV and oral antibiotics was given, but the TLC never came down. And ultrasound showed a mild splenomegaly of 13.6. This was a peripheral smear. You can see some left shift neutrophils. And very correctly, they did the bone marrow aspiration, cellular marrow with tri-lineage hemopoiesis. Advised BCR-ABL because we all know the one leukocytosis with some splenomegaly should always be CML, mostly CML. PCR was negative. And I was so impressed by this BCR-ABL fish being done, because there are a lot of transcripts which are not picked by PCR. It's only the routine transcript we do by PCR. They did the fish also, which means even atypical CMLs, the term is not atypical CML, the CML with other transcripts of PCR-ABL, they were also negative. So the patient was referred to me, what to do. So I am always comfortable doing the marrow biopsy. We did the biopsy and this is a silver stain or the reticulin stain. Can you see the fibrosis, the black one? These are all fibrosis. So this was a case of primary myelofibrosis. So we have to know that myelofibrosis always does not present with massive splenomegaly and cytopenias. There's something called the cellular phase of PMF, which always present with leukocytosis. So how do we further categorize it? Hemato-oncology is nothing without next generation sequencing. Everything has gone on to molecular. And even though we might think molecular testing is too expensive, no. Because it gives us clue of how to treat the patient, the rapidity of the evolution of the disease, the ideal treatment, the targeted therapy we are going to give the patient. So this patient turned out to be positive for SRSF2 and MPL. So what does this give me? This means that the patient is having a very high risk primary myelofibrosis. So this patient hardly has 3 to 4 years to live, even with treatment. The only treatment that might save him is bone marrow transplant, which is very difficult to do in a male of 54 years with no siblings. So haplotransplants are still being done, but the success rates are at 5 years, it's 50%. And he's a driver. He cannot afford a haplotransplant, which costs around 25 lakhs. Even in the best of centers like SGPGI with good government support. So we'll have to prognosticate, start him on JAK inhibition. Despite JAK being absent in this disease, we can still give JAK inhibition, which will, decrease the rate of development of it if it's frank AML. So this is one thing we should remember. All leukocytosis just being evaluated for CML is not enough. There's a lot of other things. The WHO Blue Book is being updated every day. I mean, we have like the 5th edition right now, even though the concept came only in the late 2000s. So yes, every leukocytosis needs to be evaluated. If it's persistent, the first thing a physician should do is, of course, give broad spectrum antibiotics. If it's not responding, go ahead with a bone marrow aspiration and biopsy. Get it reviewed by an expert or good pathologist. So they will guide us what to do further. I'm not going in detail about primary myelofibrosis treatment because it's the most complicated disease for a hemato-oncologist as well. So we do something called dynamic scoring and, titrate our doses and therapy accordingly. So this is the 5th case. This was referred to me from SGPJ itself. 41-year-old male, a carpenter from Dioria. He presented with abdominal pain, severe pain, not responding to analgesia. Triple phase CT caught an SMA thrombosis. So the bowel was already gangrenous. He underwent bowel dissection. And they were thinking, what could be the cause of this patient having, a young male, sudden onset arterial thrombosis? What could be the cause? This was a CBC 9.8, not very bad. 12,200 TLC and 5.8 lakhs of platelets. Rest were normal. And they did do the primary thrombophilia workup. everything was negative. The only thing which was catchy was 5.8 lakhs of platelets. So the patient was sent to me. The one most important, cheap, and the most effective and efficacious investigation we should do is a GBP. So pathologists to our rescue. So we just did a GBP. We could see clusters of platelets. The problem with this is, in my last talk also I was talking about, there's something called spurious thrombocytopenia. I get a lot of concerns like, platelet of 50,000-60,000, but the patient is not doing it. It is pre-op. And the patient will come to me, they do a GBP, it's 1.6 lakhs. That's called spurious thrombocytopenia because the platelets tend to clump in an EDTA sample. And the counters will calculate one clot as one platelet. And so we get an erroneous report. The same thing has happened with him also. 5.8 lakhs. And you have clusters of platelets in almost every field of his GBP, which means his platelets is around 10 to 12 lakhs. So this is something we have to be worried about. So we did a marrow, and it was a classical case of essential thrombocythemia or thrombocytosis. So we see all these big cells. These are all our megakaryocytes. Loose clusters, again, characteristic of essential thrombocythemia. And again, we did the next generation sequencing, which we found that it was JAK2 exon 14 positive. So JAK is a JAK of most myeloproliferative neoplasms. So we do get these in 50 to 60% of essential thrombocythemia as well. So JAK is a very important investigation in cytosis. So how we treat essential thrombocythemia? Again, risk stratified. Every myeloproliferative neoplasm needs to be risk stratified. The treatment varies from ecosprin once to twice daily to hydroxyurea. The one thing which we should be very cautious about essential thrombocythemia is we will be thinking it is just reactive thrombocytosis because the patient will not have spleen. Essential thrombocythemia, majority of the time, does not have any organomegaly. So unless and until we do a marrow and a sequencing, we will miss these patients. So a lot of medicine spoken. So we'll move on to the surgeons. The most important call, the most frequent call I get is peri-op thrombocytopenia. Occurs in 5 to 10% of patients. Anytime I go, there is a thrombocytopenia waiting for me. So why are we so concerned about peri-op thrombocytopenia? Do we need an expert opinion on peri-op thrombocytopenia? Let's see. If a patient is having a platelet of less than 1 lakh, whether or not the patient is having bleeding complications, the patient is not going to do as well as a patient with more than 1 lakh platelet. The patient can develop sepsis, renal complications, pulmonary infections, and even ventilator-associated pneumonia, even if he is ventilated for some other cause. We don't know the reason. We have some theories forward, but even though there is not a linear correlation between platelet count and bleeding post-op, there is always a linear outcome between the platelet count and the post-op outcomes. So it's important to get a pre-op opinion, not just because of the risk of bleeding, but to improve the patient outcome. We all know God has blessed us with 40 times platelets. We have done delivery with platelets of 25,000. My target for treating any patient with ITP is 25,000 platelets, not more than that. We are blessed. 25,000 is more than enough. Forceps, 30,000. As long as you don't have a neuroaxial anesthesia. Okay, so platelets are abundant and 10,000 is enough for thrombin generation. So why are we concerned about platelets? Because platelets is not only for clotting and pasting. It is also involved in angiogenesis and wound healing. This is exactly the why the surgeons are very rightly concerned about thrombocytopenia. So you have a patient with low platelets, he is not going to do as good as a patient with a platelet of 1.8 lakhs or above. Okay, so this is the reason thrombocytopenia is a concern. And we see a lot of misuse of platelets. So what are the cutoff of platelets? We all know 150,000 or 1.5 lakhs is the accepted definition of thrombocytopenia. We are trying to change it into 1 lakh. It's been tried for so long and it's not yet enacted because the surgeons were not very cooperative. This is the insider news. So they are not accepting to call 1 lakh as normal platelet count. So all these evidences are just suggestions, not really based on randomized clinical trials. And how these all evolve? It's from learning from hemato-oncology patients. Because my patient is never going to have a platelet of more than 30,000 as long as he's completely MRD negative from leukemia. He is going to have a platelet of 20 to 30,000. So they tried and tested all these forms of interventions in hemato-oncology patients, and we have some suggestions. So if you are doing a neurosurgery, the platelet cutoff is 1 lakh. And from now, 80,000 onwards, there is no linear relationship between platelet count and bleeding. There is no relationship. If it's a major non-neuroaxial surgery, 50,000 is enough. For most of the interventions, for any surgery, 50,000 is enough. For central line placement, 20,000 is enough. When do you transfuse? When the platelet count is less than 10,000. When there's an increased risk of significant bleeding, when the platelet is 5,000. So this I thought I should definitely convey. So now we'll come to post-op thrombocytopenia. If a patient is having post-operative thrombocytopenia, it needs to be evaluated, especially if it is beyond 4 days. Till 4 days, you have your leeway time. So the most important thing, whether you need a specialist involvement in post-operative thrombocytopenia or not, is it's beyond day 5 of post-op state. Beyond surgery, day 4, please evaluate, please evaluate. It could be also, because of DIC, it could be because of, TTP, it could be because of innumerable condition. But the simple take home is beyond day 4 of post-operative state, if you are having a thrombocytopenia, we need to evaluate. And if it is mild thrombocytopenia, that is, 75 to 1.5 lakhs, it need not be. But it's less than 75,000. You need to take your thinking caps on. So this is a case, relevant case here. 64-year-old female, avascular necrosis with secondary OA of the hip. Total hip replacement was done, was put on enoxaparin prophylaxis. Developed thrombocytopenia on day 9 post-op. Hemogram was 11.2, 8,800, 45,000. Platelet was not very low, but then it is day 9 post-op. The cutoff we had was day 4. And the pre-op counts was 12.4, allowed some amount of, anemia pre-op, 7,100 and a platelet of 3.8 lakhs. So this is where we need to evaluate. So this is something which every surgeon should definitely know. So you see, this is the normal platelet count. We see a natural dip on day 4. It is because of the trauma involved during the surgery. The platelets are being consumed. There's going to be some amount of hemodilution. You're going to be giving some IV fluids. And you know what happens when platelet falls? Your body responds. Your body is beautifully made. The thrombopoietin secretion increases. And for the thrombopoietin secretion's effect on the blood bone marrow factory to act, it takes after 5 days. So categorically and characteristically, after the day 4, you are going to see an increase in platelets. If you're not seeing it, there is something absolutely wrong. Day 5, your platelets have to start to increase than the pre-op or the peri-op platelet count. It is because of the Beachwala dip and the thrombopoietin response, and the platelets are going to increase. If it is not increasing, or if the dip is less than 1 lakh, think of multi-organ failure following sepsis, post-op thrombotic thrombocytopenia, and something which the surgeons give, the heparin bolus. It is very, very notorious. Heparin can cause rapid onset hit, typical onset hit. The previous criteria that he or she should have a prior heparin exposure is no more valid. You can have a sudden onset hit even without a prior heparin exposure. Or you are transfusing. There are a lot of causes if you are going to have a thrombocytopenia beyond day 4 of surgery. So what is hit? So I thought I will say this also, you have this heparin and you have this platelet factor 4, which is there in the platelet. This heparin has, in some patients, a tendency to bind with your PF4. And the heparin PF4 complex is very antigenic. It mounts an antibody response. So anti-heparin PF4 IgG immune complex forms, and this activates the platelets. So platelets are very active and it becomes sticky. So this is one condition where you get thrombocytopenia, but the patient's risk is because of the thrombosis. It's like TTP, thrombotic thrombocytopenic purpura. So what is the other classic example of the same pathophysiology is vaccine-induced thrombotic thrombocytopenia, which we commonly see with COVID. COVID patient presenting with thrombocytopenia, the next day she will have a CVST, cerebrovascular sinus thrombosis. So thrombocytopenia doesn't mean she's only going to bleed. So this we'll have to be very careful. Thrombocytopenia does not always equal to bleeding. Even ITP with platelet counts less than 10,000, I have seen thrombosis. Any thrombocytopenia has active platelets and it can cause thrombosis. So this is something we should always remember. And we can have DVT, we can have pulmonary embolism. The morbidity and mortality associated with HIT is pretty high. So how do we identify this in our setting. This is a 40 score. I'm sure we all know when the thrombocytopenia is not very severe. So always around 40 to 50,000, the timing of decrease, day 5 to day 10. If there is some evidence of thrombosis, there's high likelihood of it. And just thinking it to be thrombocytopenia, we cannot stop anticoagulation. This is what I want to emphasize, because the patient's risk of life is because of the concomitant thrombosis. We will have to consider anticoagulation in this patient, 101%, but not heparin, neither low molecular weight nor the conventional heparin. We'll have to go for argatroban, dabigatran, or even fondaparinux is okay. So calculate 40 score. If it is intermediate or high, we'll have to stop heparin and immediately start alternate anticoagulation so that we prevent immediate mortality and morbidity for this patient. And we have immunoassays to check for these anti-PF4 antibodies, which we are using in this vaccine, COVID vaccine-associated thrombotic thrombocytopenia as well. And that will confirm the diagnosis, and we'll have to continue the anticoagulation. So I hope the cases were entertaining enough. This is just a drop in the ocean of hematology. I hope to see more interesting cases. And I end my talk here.